Yeah, let's go to Chandigarh, PGI Postgraduate Institute in Chandigarh. Dr. Rajesh Vijayvargiya.
First of all, thanks SCAI for the invitation and the opportunity to transmit the like is from PGI Chandigarh. It's a privilege and honor to be there in the meeting. And Ramesh and other panel members, good morning. Let me introduce my team. I do have Basant with me. Basant is Associate Professor in the Department of Cardiology, working very closely with me. And then I do have my senior resident, Dr. Chaudhary, Dr. Krishna, and Dr. Tanuja, and Dr. Bose. And then I do have a technical team with me. So may I request Dr. Basant to go ahead with the PowerPoint presentation of this particular case, please? Basant.
Thank you, sir. Next slide, please. Yeah, we don't have any conflict of interest here and nothing to disclose. So the case history, here we have a 63-year-old hypertensive female presented with stable angina class 2, which progressed to class 3 since last 1 month. And the clinical examination is unremarkable. There is no significant STT changes, echo showing the concentric LVH, no mitral regurgitation, and good ejection fractions. Her creatinine is 130 micromole per liter, and eGFR is 40 ml per minute, 1.73 meter square. And ABI is 1 in the bilateral lower limb. You can see the ECG has no significant changes. The echo is showing the concentric LVH and good biventricular function. Next slide, please. Yeah, we have a significant past history having the coronary as well as the aortic involvements. So 10 years back, she had undergone PCI to proximal LAD, 3 into 40 mm drug-eluting stent, and proximal LCX 3 into 13 drug-eluting stent in the April 2013 was implanted in another hospital. And the next lesion was the second aortic iliac lesion, where 2.5 years back she had undergone aortic iliac stenting for the juxta-renal aortic obstructions at our institute, August 2020. Here you can see the angiography which was done a week back, showing the left main disease, the Medina class 111, and the significant LAD ISR in the mid around 90%, and the LCX stent was patent. Here in another view you can see, and the RCA was non-dominant, and the aortic iliac stent was patent with good flow in the lower down. Yeah, this was the lesion which was taken in August 2020. There was significant obstruction at the juxta-renal aorta. The gradient was 40 mmHg. The left renal artery and the inferior mesenteric artery was 100% occluded. The right renal artery, the superior mesenteric artery, and celiac trunk was normal. So aortic intervention, you can see here, 18 into 90 mm wall stent was deployed, and here also the bilateral 10 into 80 mm sirolimus eluting was deployed, absolute pro vascular. We have a good result in both the iliac and the aorta. So now the summary, we have a case of left main bifurcation disease with left dominant circulation with late ISR of LAD, and the plan is that we have to give a LM LAD crossover with a provisional stenting with and of course under the image guidance. Thank you, sir. Over to you.
So Dr. Ramesh, this is the case, and this is the first angiogram. We had certain difficulty in pushing the guide catheter. That's a EBU 7F across the aortoiliac stent. And then this is what we do have the aortic, this left main bifurcation lesion, 111 Medina. And there is a certain crescentina effect because of the wire across the left circumflex. Next view.
Yeah. So let's hold off there and
Yes.
let's ask the panelists here, Dr. Rajesh, Dr. Tariq Helmi is here, Dr. Kwan Lee, Dr. Badr from Saudi Arabia, and Dr. Eldin and Dr. Kasha from Egypt. Okay, so let's ask Tariq, what do you think? This is a really good discussion we can have, right?
It's an excellent case. I think you're dealing with a left main bifurcation 111 Medina. EF is normal, and you have your strategy. You have to decide whether it's provisional stenting or two-stent strategy, given the disease in the circumflex and involvement of the osteal circ as well. I think it would be a reasonable approach to consider a dedicated two-stent strategy from the offset and consider a DK crush as one of the strategies to go forward with this.
That's good. Dr. Badr, would you OCT or IVUS?
I think I would definitely imaging is critical in this case, given the fact that aneurysmal part in the circ, in addition to evaluation of the osteal circ disease and sizing too.
Okay.
So you see that aneurysm. But agreed with DK crush. Medina 111 and IVUS.
Yeah.
And do two-stent strategy with DK crush.
Okay, so let's see, and then we'll come back to the next questions. You all agree that so far the recommendations of DK crush and imaging guided. Dr. Alfaraj.
I think culotte 2 will be a good option in this case.
Yeah, agree.
I think it is a very challenging and very interesting case, and I'd like to put on the table the solution of using the DCP as a solution. I know it is out of evidence, but in the presence now of sirolimus eluting balloons also, I think we could think about, because a heavy metal in this area would be
right.
a future.
Absolutely right. Actually, one of the companies which is making DCB is from India, Concept Medical. They are going to start a US trial, which we have been asked to be one of the sites for that. Magic Touch is a balloon. It's a sirolimus eluting balloon, and Dr. Vijay Varghese has a vast experience in that as well. So so you heard all the comments. Yes. Two-stent technique versus single stent with the drug-eluting balloon. But before that, everyone agreed we need imaging. So go ahead, please.
Right. So we have done the imaging of both the LAD and also the left circle. Can you run the LAD OCT? Can you display the OCT, please? Big screen for the OCT. Okay, here we are. So this stent is 3 millimeter. The distal site is around 3, while proximally it's a 3.6, 3.7, something like that, the dimension, and you can very well appreciate the under-expanded stent in the proximal and also the distal part. Can you rerun it? The minimal luminal area is how much? 1.54. So it's a diffuse intimal hyperplasia after 10 years of DES implantation across the LAD. There is some calcification at the proximal part as well. Okay, next angio. Can you back, वही वाला. Yeah, इसको चलना. So can you display the angiogram, please? We had some problem in pushing the catheter across the left circumflex. As you know, there is a certain difficulty across the angulated coronary for the OCT, but ultimately we could position it very well, and then had an OCT run across the left circumflex. So can you run the OCT? Kindly display the OCT run for the left circumflex. Yes, here we are. So this is the OCT run. Approximately the vessel is fine. Only at the ostium there is a significant disease. How much is the MLA at the ostium? It's a 1.73 millimeter square. So basically it's a simple bifurcation left main lesion, and then as you have already discussed about 2 stent versus 1 stent, so that point can be very well discussed over here. Any comment about say functional assessment for the LCX?
No, that's very good. So that this aneurysm here you see in the distal, can you go back there? And there was a stent, huh?
Absolutely right. There is a stent at the proximal left circumflex, and this aneurysm is nothing but the crescentina effect because of the wire across the left circumflex. So this is the normal vessel, and you can very well appreciate this band over here at the OCT. Can you go up to 10, around 10 or back to 10? This particular point. So this is what next. And we have shown the diagnostic angiogram in the PowerPoint, so there was no disease as such other than the ostium of the left circumflex.
Okay. All right. So now what would you say, Dr. Quanley? You saw the OCT. What have you changed your mind from earlier DK crush?
Yes, still DK crush.
Okay. How about tell me?
I think the DK crush, and he's needing good preparation for the lesion. Too tight. Then we see angio.
Okay. So
Yes. Yeah.
how would you do the plaque modification, Doctor?
From OCT calcification,
What will you use? What device will you use?
Heading to the
I will start by NST balloon. The calcification is not heavily calcified as NC, if not cutting balloon.
Ma'am, you okay with that? Yeah. So, yeah. Provisional. Right. That's why Dr. Vijayvargiya also said it's a simple bifurcation. The lesion length is not very long in the circ. So what are you deciding, Dr. Vijayvargiya?
Okay, so just to be sure about the significance of the ostial LCA, we have passed the FFR wire across the left circumflex, and then it's a baseline 0.85 point post adenosine. It turned out to be. Can you display? Yes. Can you go to back? So this is the baseline 0.85. Next, and post adenosine it turned out to be 0.66. So it's a left dominant circulation, and with a baseline FFR of say 0.66, we decided to go ahead and take care of the LCX as well. Next view.
Okay.
So this is what Ramesh. This is basically a wire-induced some aneurysmal like formation, which is all nothing but say wire effect across the proximal LCX, and we are dealing only with the ostial LCX, which turned out to be having very functionality significant with the FFR value of 0.66. Next view. So here we have dilated with the 2.5 millimeter balloon across the LAD. Next. And this is again 2.5 millimeter balloon across the ostium of the LCX as well. Next.
Which type of balloon?
It's a semi-compliant balloon at 12 or 12 atmosphere, just to have nice space across. Next. And this is what, and then we have taken the cutting balloon. It's 315 Wolverine from Boston Scientific. So this is the 315 balloon across the left main to LCX. Next. At this point, the patient blood pressure, which was 170, opening blood pressure dropped down to 90. We started with inotropic support. Next. And then the LAD was also dilated with a 3 millimeter cutting balloon. In the mid part, distally was not able to push the balloon across. As the patient was getting deteriorated, we immediately put a stent 3.5, what's the length? 3.5, 12 millimeter Giants alpine stent across the ostium of the LCX. Next. and been crushed by a 3 millimeter NC balloon, left main to LAD. And this is what the distal LAD, mid LAD having significant ISR. At this particular point, we were not able to push our cutting balloon. Next. And then we again tried with the cutting balloon at this point as well. This is 3 millimeter NC. Next. Next. And then we had a cutting balloon as well. Next. This is the cutting balloon 3 into 15 millimeter across the distal part. So this is what we stopped. So Ramesh,
Yes.
till now what we have done, we have put a stent across the ostial LCX as a mini crush. As the patient was having hemodynamic instability, we proceeded very fast and open up the LAD with adequate plaque modification. We have used the cutting balloon at 18 atmosphere across the whole of the LAD and also dilated the LCX ostium with the cutting balloon, and prior to that it's a 2.5 millimeter balloon. So at this point,
that's excellent,
any opinion about say drug-eluting balloon versus stent?
Yeah.
I do also believe that we need to choose a stent with the less stress thickness because also here we were trying to get away from the heavy metals. So I think if we are going to plan for stenting, I think, I don't know what is the opinion of the panel, but I think using the stance of the less strut thickness is wanted here. I don't know.
Paul.
The OCT images, did it show new atherosclerosis in that area, or it did?
It did.
Okay, sorry.
So I agree. I think, we only have one Osiro, which is 65 microns. Otherwise, all our stent strut thickness are about 85, 80 to 90 microns. So yeah, so I think I don't know whether the long-term data has been really so in favorable of ultra-thin struts yet. I know there's probably some 5-year data that's coming up which shows positive influence on the TVR, and with the ultra-thin struts, we have to wait for that. That said, Doctor, I would have used a little bit longer stent in the circumflex, and I think there was a post-stenotic dilatation in that, even though you thought it was concertina effect, but I thought it was post-stenotic dilatation, and I would have just covered that up to beyond that a little bit close to the OM1 aneurysmal segment. So, Dr. Vijayavargiya, what about the drug-eluting balloon? I think that's a good option, but I think if there's a dissection, Dr. Colombo has been showing excellent cases leaving LAD dissections with even after drug-eluting balloons, but he would definitely do an FFR and shows that FFR can be brought up to at least 0.90 and above, and then so I think it all how comfortably you can go back to sleep. I'm not, so I would go ahead with stents.
Very nice. We do have the lesion distal to the LED stent, and then it's the left main bifurcation. So otherwise also I'm going to put a left main to LED stent, and therefore I decided to go ahead for the drug-eluting stent instead of a drug-eluting balloon. So next view. Next, so this is 338 Giants Alpine across mid to distal LAD. The distal reference was 2.8 across the LAD in the OCT. So this is at the nominal pressure deployment of the 338 Giants Alpine. Next view. With a good flow across it. Next view. And next view. And this is 3.5 33 from left main ostium to the mid LAD. Again the Giants Alpine. Next view.
3.5.
And then we have dilated the whole of the stent with say 3 millimeter distally. Next view. 3.5 over here in the proximal part. Proximal 18 millimeter is of 3.5. Next view. Next view. And this is 4.5 as the left main was a 4.5 millimeter in the OCT, so 4.5 pot. Next view. So any comment, Ramesh, by this
Yeah, I
up
think,
to this
I mean,
extent?
yeah, it looks good. Is there two stents in that circumflex and there's a gap, or I'm not able to?
He didn't cover the gap, I think, or
So
So that can be imagined very well, but then fluoroscopically, let's have a look, and then this is the cine, live cine, and then if you see, we have covered the ostium of the LCX very well, but then it's the imaging which is going to demonstrate everything. Go back, back.
So
Kissing.
they
Back,
did the
back.
kissing.
so pot was done, recross was done, and many people would
Next
go
you,
for
next you.
final kissing
No, I think you did something which is really great that maybe most of the operators were not gonna do it. At the moment that the patient crashed and his blood pressure went from 170 to 90, and with this apparent dissection that we have been seeing, you proceeded, you just put the stent of the LCX, which was a brilliant idea, because maybe when you have this situation, you will just put the stent of the left main LAD, and then you will think what you are gonna do, because your patient is having a chest pain and he is his blood pressure is going down. It will make your life very miserable, actually, to try to recross with this very difficult angle of the LCX that you already had some difficulty while wiring it in the first place.
Okay.
So I think it was ideal that you just put the stent in the LCX, and then you stabilized your patient, and you continued as your plan. This is good.
Okay. So we're going to finish in 10 minutes. Dr.
So-
Prashant Kaul, you got up, and anyone in the comments and from my partners over there can come to the microphone.
Yeah, just a quick comment. I think it's a excellent case. Congratulations, well done. I probably would have also ended up stenting and suggesting a two-stent strategy up front. The only comment I was going to make is that when you're doing FFR in the setting of a pseudo lesion, you just have to be careful that those results may not be interpretable. So just I think regardless of the FFR, I think you would have still ended up with a stent in the proximal circumflex, but that FFR of 0.66 within the setting of a pseudo lesion may have been artificially low.
Right.
Just a
And to the FFR point as well, I was just curious about the strategy of FFRing as a decision to whether you should choose provisional or not, because even if the FFR is negative, modification of the left main LAD may then change the lesion after that. So the question is it better to then FFR after that initial point as a decision to whether you convert to a different thing? Because the lesion changes beyond there.
That's what was presented at Euro PCR yesterday, actually. So post left main bifurcation PCI, you do an FFR of the side branch that is still probably has some value. And because DK Crush 6 said there's truly really no difference between FFR guided side branch assessment after PCI, but this study now shows that there is some value to it. Dr. Jagadish.
You stole my thunder
The
because
OCT images did show a very tight cervical stenosis before
Right.
the eye.
this is a very good two cases. Obviously, the choice up front was two stent strategy up front. But I wanted to bring up, going off of Ramesh's comment, we have very hot up. I'm going to leave you with a philosophical question: is now that we have hot off the press data from Euro PCR, EBC main, and EBC2 that just got presented, now supporting that in a randomized fashion in the left main as well as non-left main bifurcations, that a stepwise provisional strategy is actually better, or non-inferior, actually superior in terms of target lesion failure and all of that in a bifurcation. So now many of the European experts are saying, what is the need for a second stent anymore, for an upfront two-stent strategy? And now you have robust randomized clinical data in the left main as well as non-left main bifurcation that we may not need to do two-stent upfront strategies anymore. And that's being supported by
I think it's
good
yeah.
evidence.
I mean, it's a great point, but I think it's important to point out that not all left main is created equal, and the Asian dichotomization into complex left main versus non-complex left main, complex left main favoring a two-stent strategy is still important. You can't just take all left mains and say that provisional is best. You have to dichotomize it and score it, whether you're using a definition score or whatever it is.
And remember, in this case, it's a left dominant system. Sir,
Right,
we do
yeah.
have FFR that showed a significant lesion. Also, the OCT data showed.
Okay. We have to go to the, Dr. We'll come back to you. Okay,
Fine.
let's go,
So,
Dr. Vijay. Maybe you can show in 2 minutes.
Okay, Ramesh, so what we have
Or
done...
we can go to Apollo and come back to you.
Fine,
We'll
fine.
go
By
to
that time,
Apollo.
fine. Good,
Yeah.
go ahead.
Thank you. Dr. Rajesh Vijay, we are back with you.
Okay, fine.
So you can probably...
So after doing the final kissing and also the port with the 4.5 across the left main, at this moment of time, instead of say OCT, we have gone for the IVAS. Can we have the run of the LED IVAS? So this is the LED run with the IVAS well expanded and opposed stent.
So from OCT, why did we switch to IVAS, Dr. Rajesh?
Yes. So here we have extended our stent up to the left main ostium, which is going to be somewhat difficult with the OCT to have a good imaging across, and therefore we now shifted to the IVAS to look for the left main ostium and of course the rest of the vessel.
Yeah.
Second thing with the OCT, you are supposed to have the selective cannulation, and I don't want to have the selective cannulation of the left main ostium to avoid say stent deformation. And therefore we preferred over here, initially it was to put the stent from the mid part of the shaft of the left main to the LED, but then as there was a disease at the ostium as well, and therefore we extended our stent 3.5 millimeter stent from left main ostium to the mid LED, and therefore at this moment of time we decided for the IVAS. Can you show the mid or proximal part of the LED? This is the point. This is the point where we do a certain under expanded stent in the proximal LED with the area which is 5.91 millimeter square. So we are again going to have a post dilatation at the high pressure with the 3.5 millimeter balloon. The vessel size over here is 3.7. Next, run it and show the left main as well. So this is the point where there is the under expansion. Here comes the LCX ostium.
I mean, 5.9, I think you can leave it alone. What do you think, Tarek?
Yeah, I mean, your usual optimal cutoff is 6 millimeters square, and 5.91 is very, very close. It depends on how perfect you want the result to be.
See, at this point, we had an in-stent restenosis, and therefore I feel like let's have the balloon dilatation at this point with the 3.5 at high pressure, 18 to 20 atmosphere to achieve the better area. Can you run the IVAS of the left circumflex as well? And meanwhile, let's inflate it. Okay, 6, 8, 10, 12, 15, 18, 20.
Can we see the X-ray?
He wants us to see this.
No, he's dilating now.
So this is the run, Ramesh, across the left circumflex. You can very well appreciate there is certain malopposition of previously deployed stent in the proximal, and this is the area which you was talking about, say aneurysm. It is somewhat. Can you show the healthy area in between the two stent? So this is what this area which seems to be say aneurysmal on the angiography, which is somewhat healthy over here in the IVAS image, and go to the proximal part. Okay, run it. You can very well appreciate over here the coverage of the ostium of the LCX with the stent struts, and there is no apparent gap between the left main and the ostium. So here is the transition from LCX to the left main.
Yeah.
With the appropriate coverage of the LCX ostium. LCX ostium is having the area of how much? 11 point? 10 point?
Yes.
10.45 is the area across the ostium of the LCX. Next, left main. This is the left main ostium.
It looks big.
And meanwhile, Ramesh, we have dilated the proximal LAD with a 3.5 NC
Yeah.
balloon at 20 atmosphere. So hopefully the area is going to be on the higher side by now. Can we have the, if we have the time, we can very well have a run across the LAD again to look for how much is the improvement in the area after having a 3.5 millimeter balloon dilatation. So let me
I
go
think
ahead.
you can do a final angio for us, and
Okay,
can wrap
okay.
up, and then you can
Fine,
do your
fine.
IVUS later on. But I'm sure it'll be much more than 6 millimeters. So you would have achieved that comfortably with the non-compliant. Last time when we were with you, Dr. Alfarag was going to say something. I'll give you back the time to ask a question.
We have to, especially in the left main bifurcation, we have to optimize by imaging and also maybe by physiological assessment, because as shown in the last a few days ago that the residual ischemia will affect the mortality very high. So I do agree that we have to do a better optimization by imaging and physiological assessment.
Yes, absolutely. Beautiful. I think that's really excellent, demonstration of a mini crush or nano crush with complex left main PCI and dominant circumflex, and with the imaging as well as FFR use. I mean, as we said, that I think imaging here has been very helpful in preparing the vessel with the Wolverine, and also with a couple of stents and post dilatation. So thank you very much, Dr. Vijayvargiya. Any last comments?
Thank you very much.
Yeah, I think your choice of stent length as well as stent sizing was excellent, and your final result, I think, speaks for itself. Excellent case, excellent result. Congratulations.
Thank you very much. Thank you, SCAI.
Thank you. Anybody else from the panel? Any comments?
No.
No.
Nice result.
Thank you.
Thank you.